Good morning, ladies and gentlemen. The topic of today is the female genital organs. The female genital organs consist of two parts, the internal and the external one. The internal then comprise the gonad, which is called ovary, and then a paired tubes, uterine tubes or salpinx, and then an unpaired tubes, uterus, following by vagina. And we can find some small embryonal remnants from mesonephric duct of wolf and from mesonephric tubuli, which we will talk about. We start with arrangement and position of the internal female genital organs. They are located in lesser pelvis, and during pregnancy, the uterus enlarges and extends up to the abdominal cavity as far as diaphragma, and it takes the ovary and the uterine tube with it up. You can see that the position here in the figure, that the position is behind urinary bladder and in front of rectum. That's the main position of the organs. They are mainly located in a frontal line, but as you can see, uterus is flipped ventrally and vagina is flipped dorsally. The main structure which keeps all these organs in one flexed plane is called broad ligament of uterus. What is a broad ligament of uterus? It's a doubled layer of peritoneum. So when I come back, you can see here in this figure peritoneum. When I change the color, the peritoneum is covering all the lesser pelvic organs from above. So we can consider these organs subperitoneal. And subpart of them, of course, they are covered by peritoneum, so they are partially intraperitoneal, but mainly subperitoneal organs. So on the section, we can see that uterus is covered from anterior side partially and the whole posterior side. And on lateral sides, these two parts, they come into one layer. So we can see it here. And this part is then called the broad ligament of uterus. So to the sides, it forms this duplicature or a double layered peritoneum, and it comes then to the wall and continues adjacent to the wall. So this broad ligament or ligamentum latum, it helps to fix uterus in a frontal plane. I'm sorry, here is a mistake. It's not sagittally oriented, but it's frontally oriented. But as I showed before, it's a bit flipped, and we come to the details later. So it's frontally oriented, double-layered peritoneal duplicature. And as you can see here on the section on the right, it covers not only uterus, but also uterine tube and ovary. And the ovary is located, as you can see also in this figure, it's located dorsally to the broad ligament. So this is direction dorsally. So again, all these organs are covered by peritoneum, so we can consider them intraperitoneal, uterine tube, ovary, and uterus. And then vagina is subperitoneal organ. And here is a specimen taken out, and nicely visible uterus and ovary and the uterine tube, as all they are covered by peritoneum. I'm sorry. And on the side, we can see the broad ligament, the ligamentum latum of uterus. What is inside ligamentum latum are the vessels, which we can see here, and also a ureter, which is coming behind. And a photo from a real patient from laparoscopy. This is uterus. Dorsally, we can see a fat pad encircling rectum. And this whitish structure is ovary, and this is a uterine tube. So this space in between is the rectouterine pouch of Douglas, which we already know from peritoneal cavity structures. So and we start with the gonade, which is called ovary, and in Greek ophoron, which means organ which produces ovum, eggs, ootids. It's quite small, 1 by 2 by 3 centimeters. Its weight is less than 10 grams, and it's a bit flattened organ. And the function is to produce during the embryonal time to produce the eggs, which we better call ovum, more ova or ootids, and then then during fetal time and after birth, then they maturate here. They are not produced anymore, unlike sperms. On the other hand, their number is successfully reduced. Successively reduced, as we will see later. So their full number is produced during 2nd to 4 months of prenatal life, and then it's reduced. So maturation of ootids and secretion of sex hormones, estrogens, and progesterone. As we said, it's all covered by peritoneum. So it's considered intraperitoneal organ, and it's located on the posterior side of broad ligament of uterus. It's of course located in lesser pelvis, and the position is between external and internal iliac vessels, below the bifurcation of the common ones, and we call it ovarian fossa. This ovarian fossa is the location of ovary only in ladies who still have not given birth to a child. Then after delivery, all the organs are a bit stretched. So even the fixation apparatus is more relaxed and loose. And that's why the ovary returns a bit lower and more dorsally. So behind the internal iliac vessels, so they are located between internal iliac vessels and the bone, which is sacral bone in this case. And we call this a fossa of Claudius. It has got no systemic name, just called a fossa of Claudius. Concerning microscopic morphology, we can distinguish several parts: a uterine pole and tubarian pole. Uterine pole is located medially, and tubarian pole is located laterally. And we have a medial and lateral surface, which we can see. So medial surface is visible here, lateral surface is on the other side. And then 2 margins. One margin is free, and the other margin serves as attachment of the peritoneum of the broad ligament of uterus. And the whole part is called mesovary, so it's called mesovarian margin, margo mesovaricus. And on the figure, we cannot see the hilum, but the hilum takes the vessels coming from above, the ovarian vessels and nerves, into the gland itself. How it's fixed? As we said, it's covered by peritoneum, so there's the duplicature which connects it to broad ligament, which we called mesovarium. And mesovarium, it's a part of the broad ligament. And then it's fixed medially from the uterine pole to uterus, close to the uterine horn, which is called proper ovarian ligament. And its function, it's not very important. And much more important is the fixation function of suspensory ligament of ovary, which also contains the ovarian vessels and nerves. We can see that there is a close relationship to uterine tube, mainly functionally, and the uterine tube is also fixed as a part of broad ligament, and we call it mesosalpinx. Salpinx is an old name for uterine tube as well. What about the blood vessels? Both gonads, testis and ovary, they develop from intermediate mesoderm or inside intermediate mesoderm at the level of L2, and they have to descend. Testis descend through inguinal canal as far as scrotum, ovary only into lesser pelvis, to the ovarian fossa. So it takes blood vessels on the way from the level of L2, so ovarian artery branches from the abdominal aorta, but it is located inside the broad ligament, so it is also supplied by ovarian branch coming from internal iliac artery and uterine artery in between. And there are mutual anastomoses, which form so-called ovarian arcade. The veins are drained via very, very short pampiniform plexus, similar to that of the male, but very short. And then we have a doubled ovarian vein with mutual anastomosis, and it drains on the right side directly to inferior vena cava, as the inferior vena cava is located on the right side, so it's shorter way. On the left side, it has to cross abdominal aorta, so it's better to drain directly into left renal vein, which then drains into inferior vena cava and crosses aorta. The lymph nodes, the regional lymph nodes are at the level of L2, and they belong to the groups of lumbar lymph nodes. And here we can see ovarian artery coming from abdominal aorta from the level of L2. And we can see ovarian branch coming from internal iliac and uterine artery. And both of them forms here an ovarian arcade, giving branches into the hilum of ovary. We can also see the blood supply of uterine tube. So it's supplied both from ovarian artery and from uterine artery by tubal branches. And we can see that the uterine artery also gives branch here to so-called round ligament of uterus, which then continues into inguinal canal. The uterine artery also gives branches down to vagina. So the uterine artery supplies not only uterus, but also ovary and the uterine tube and vagina. And vagina and ovary has got its own artery as well. Concerning the innervation, it's innervated by vagus nerve and sympathetic trunk. So it's identical to testis as well. Internal structure, it's much more complicated, and we should start to talk about the surface. The surface is very specific. As it is covered by peritoneum, you would expect a flat, simple epithelium. But here on the ovary, an original coelomic epithelium remained, which is simple, but is cuboidal, and it contains microvilli. So this used to be the epithelium of the original coelomic cavity, and this then changed into mesothelium, but not here on ovary. That's why this remnant has got a special name, and it's called Müllerian one. As you know, the Müllerian duct is the paramesonephric duct, which gives rise to uterine tube and uterus and part of vagina. So Müllerians refers to embryonic background. And officially, it's called very easily a superficial epithelium, so simple cuboidal with microvilli. And very important for clinics is that there's a sharp borderline with the mesothelium covering the rest of the cavity, in this case, mainly mesovarium, mesosalpinx, and the broad ligament. And this sharp borderline is called a Farr-Waldeyer's line. And a tumor can appear at this borderline. Below the superficial epithelium, we can find the whitish layer, which is called tunica albuginea, similar to the testis one, which is quite tough and composed of mainly collagen fibers. And below, the stroma ovarii is located, composed of the connective tissue, collagen and reticular fibers, and fibroblast mainly. And we can distinguish the deeper one, which is called medulla, and the much more important superficial one, which is called cortex. And the most prominent structures visible in the connective tissue are called folliculi, ovarian folliculi. And except these folliculi, we can find bodies which are called corpus. And these bodies are in different stage of development, as well as the folliculi. And we can distinguish them according to the color. So we have a yellow corpus luteum, red corpus rubrum, and white corpus albicans. So let's go to details. Starting with medulla, it's mainly connective tissue. It's loose connective tissue with some nerves and vessels. And concerning cells, there are only cells which are developmental alternative of Leydig cells of testis, the interstitial cells which produces androgens. So also here, some amount of androgens is produced, and we call these cells hilar cells, as they are located in medulla close to the hilum of the ovary. How to distinguish medulla from cortex? No folliculi. So it's the internal part with no folliculi. So that's all for medulla, nerves, vessels, loose connective tissue, and hilar cells producing androgens. So if you look at the figure, you see fibroblasts and vessels. That's it. So cortex contains connective tissue and folliculi. What is a folliculus? A folliculus contains one ovum, one oocyte, and it is surrounded by follicular somatic cells, which are arranged in a different arrangement based on a stage of the follicle development. We call these follicular cells granulosa cells, as they later contain granules. The follicles develop from a primordial one as far as the mature Graafian one. And at the later stages of the development, the other cells around, so the connective tissue stroma cells, they form a capsule, which becomes also endocrinely activated. And we call them theca cells. Theca means a capsule in Greek. So we have an ovum. Around the ovum, we have follicular somatic cells, which we call granulosa cells, with endocrine activity. And then later, you can see that a cavity appears. So we will have the granulosa cells as well as here. And then the last layer is this one. And these are the stromal cells forming a capsule, a theca or theca. So we call these theca cells. So now let's go through the development of ovum and then development of the follicles. So the development of ovum has got two phases. One is phase of division, which appears only during development, and then phase of maturation, which appears then before and during ovulation and pregnancy. The phase of division is easily a mitotic division, but the phase of maturation is similar to sperm's meiotic division. And we can find the different stages of the development in the ovary. What is the origin? The origin are the germ cells. They come from epiblast. From epiblast, they move to yolk sac, and from yolk sac, they migrate along ventral and dorsal mesogastrium into intermediary mesoderm. And here they provoke the coelomic epithelium to produce medullary cords inside the future gonade. And the germ cells comes into these cords, so-called medullary cords, and they proliferate there and they change into oogonia. And then they multiply and multiply. And even before birth, they start the meiotic division, but they are stopped in the prophase of the first meiotic division before birth. And we call these primary oocytes. So they are similar to primary spermatocytes, but the primary spermatocytes, their period is 22 days, but here the period can be some 13, 14 years up to 40, 45 years. So then after birth, we wait until puberty when there's a change of hormones levels. And then finally, the ovulation, the oogenesis continues. And the follicles start to change as well. And when they come to the last stage of a mature or Graafian follicle, the ovulation should start. And just before the ovulation, the first meiotic division is finished. So we come from a very, very long period of primary oocyte to the stage of secondary oocyte. And of course, by the meiotic division, a polar body is produced. And then during ovulation, The secondary oocyte undergoes the second meiotic division, and it's arrested again, but in metaphase. And then this oocyte continues and meets a sperm, and if it's a sperm, a fertilization can occur. So the second division is finished finally, and the mature ovum develops, but it is then very quickly fertilized by sperm, and we have a first stage of zygota, morula, blastula, and blastocysta, and then it continues into uterus. It nests here, and the development of embryo starts. So that's in a short the development of ovum or genesis. The details will be given in histology, don't worry. And the ovum, as I said, is all the time hidden inside a follicle. And we have millions of primordial follicles. And then they develop via primary, secondary, tertiary follicle to the mature or Graafian follicle, which then ruptures, as we can see here. And the secondary oocyte is released. And what remains here are then called bodies or corpus. The first one is full of blood, so it's called hemorrhagic or red one, so it's called corpus rubrum. Yeah, mainly here you can see still the blood inside. And then it changes into an organ producing hormones, and we call it corpus luteum. Luteus means yellow in Greek. And in case there is a pregnancy, so fertilization happens, then this corpus luteum changes finally after delivery into a small scar, which is called corpus albicans, a whitish one, which is just a connective tissue scar visible on the surface. So here we can see a drawing also of all the types. And so we start with the millions of primordial follicles, and then we change to primary and secondary and tertiary one into Graafian follicle, which then ruptures, and you can see here the oocyte, and then a corpus rubrum and a corpus luteum, and after pregnancy we can see this, which is the remnant corpus albicans. All this happens in cortex. In the center we have medulla with blood vessels and some hilar cells which can be found here producing androgens. More details to study at home, and we start with the primordial follicle structure. It's very easy. We have an primary oocyte here, and there's so-called zona pellucida here. What is a zona pellucida? Between oocyte and the granulose cells. The granulose cells form here one layer of flattened cells, so we call them either flattened follicular cells and then later granulosa cells. So it's a simple squamous epithelium. And both of these cells, oocyte and these flattened follicular cells, produce glycoproteins and proteoglycans. They secrete them in between, and such a protective layer called zona pellucida appears here. Pellucida comes from lux, lucis, which is light. So per lucidus means transparent. So it's a transparent zone containing only these proteins. And that's why we cannot see any nucleus in here. So that's a protective layer, which is kept there until the fertilization. So these primordial follicles are nicely visible here. So what is well visible is the ovum in the middle, and then a very, very light pink zona pellucida, and the simple flat epithelium is not well visible in this magnification. Of course, on the surface we can find the superficial epithelium and below the tunica albuginea, and then this is cortex, and here we have a medulla. In medulla can be a vessel, which is this one, and in this case we can see a cyst, which is a pathological structure in this specimen, but it often appears in ovary. When we come closer, an oocyte, primary oocyte here, and zona pellucida here, and a layer of flattened follicular cells here. So that's the primordial follicle. When the primordial follicles in puberty starts to change into primary follicle, what happens? The follicular cells, they get bigger and proliferate. So we have more of them, and they get cuboidal. And finally, they get columnar. But in primary one, we have simple cuboidal ones. They start to accumulate lipids, and from lipids they produce then hormones, so then we call them granulosa cells. So in the primordial one, we call them flat follicular cells, starting to develop into primary, and we change the name into granulosa cells. They contain the lipid granules. And the zona pellucida gets larger in between these cells. So when we come closer, we can nicely see the primordial follicle with the flat follicular cells, and primary follicle with already higher cuboidal cells. So these are already the granulosa cells. Primordial follicle here. And here, if you look at this follicle, there is not one layer, but more of them. So this is not a primary one, this is already a secondary follicle. So you can see what happens. First is change of height of the cells from simple to cuboid and then to columnar, and then changing from simple to stratified. So here is a primordial follicle and late primary, as you can see that the cells are really high. So this is late primary follicle with columnar granulosa cells, and of course the oocyte and zona pellucida from glycoproteins and proteoglycans. Around the primary follicle, the connective tissue of cortex starts to form into the capsule, which is then called theca. And the cells are called theca cells. And here we can nicely see the zona pellucida, which is composed only of glycoproteins and proteoglycans. So as I said, when the number of the cells, when the number of the layers starts to change from simple to stratified, we call it already a secondary follicle. And the secondary follicle has got already a prominent theca around, and the theca cells are the stromal cells, which also starts to contain lipid granules, but not so not in such a number as the granulosa cells. So coming to the detail, we can again see the oocyte, Yeah, and the zona pellucida here, and the stratified epithelium of the follicle, so the granulosa cells, and then the theca here. So it's still growing and growing. And now we come, the oocyte is 150 micrometers big. And when we come to the tertiary follicle, it is already half a centimeter. And as the number of cells is too big, then cavities start to develop inside. And we call them Cole-Exner's bodies. So cavities appears here between the follicular cells, and they are filled with the fluid. And finally, these small vacuoles, they merge and they coalesce into one cavity, which is called an antrum of the follicle. Yeah, the granulosa cells, they really formed again an epithelium here. And it's called granulosa, and the cells are really full with lipid granules to start to produce the steroid hormones. And the oocyte is not located in the center, but it's still connected to one side of the granulosa cells. It forms this, which we call a small hill, cumulus oophorus. And the oocyte is still surrounded by zona pellucida, but also by one layer of granulosa cells, which we call a corona radiata, a radiate crown. And this then will also remain with oocyte after ovulation and releasing from the ovary itself. So that's the tertiary follicle. Around tertiary follicle, we have quite compact theca, and the theca can be now divided into internal part, and the internal theca will be endocrinely active, so it will also produce steroid hormones. And then the other part, which is just arranged circularly, and it's external theca, and these stromal cells are not endocrinely active. So to review the tertiary follicle, we have a cavity antrum, and granulosa cells, they also surrounds at the margin of the antrum, they surround the oocyte and zona pellucida and form so-called corona radiata by one layer of the granulosal cells. And the whole follicle is encompassed by internal and external theca, and the internal theca and the granulosa are active producing hormones. So some more figures to show a tertiary oocyte here with the cavities, with then coalesce into one common antrum. And here we can see the internal theca cells. Again, similar figure. A number of primordial oocytes here, and the internal theca, and then the external theca is just what is around. You can see some vessels in the internal theca as well. More figures for the same, and here may be better visible the internal theca and the external one. And next to the external are other stages. Again, we can see here some primary follicle. So in here, in the tertiary follicle, the cavities, which then form the antrum, and the granulosa cells in here, and the cumulus oophorus is here sectioned transversely, so we can see it still attached on both sides, and corona radiata around it. And this is an ovary of rabbit, and in the ovary of rabbit we can see different stages of follicles. So from the primordial one, continuing to the primary and secondary, and we can see here the cavities of the tertiary ones. Here is a medulla with vessels, and on the surface we find a superficial cuboidal simple epithelium, and below tunica albuginea. So the rabbit's ovary features all types of oocytes and one. And again, a nice tertiary follicle with the internal theca and external theca, and which will then produce estrogens, and granulosa cells, which will produce progesterone and a bit of androgens, and the antrum with the fluid, and oocyte with zona pellucida and the developing corona radiata here. So this can be considered as cumulus or forus. So similar figures for home study, and we can come to the matured Graafian follicle, which is enlarged, nicely visible by naked eye, 2 to 2.5 centimeter, and it's protruding on the surface. So it's thinning the capsule, and the capsule is then ischemic, and then it can easily causes a rupture, and it's caused by increase of hormone level, and it's luteotropic hormone produced by anterior lobe of pituitary gland of hypophysis, and this increased level produces ovulation, so a rupture of follicle, which then is continuous with the second meiotic division of the primary oocytes, and it changes into a secondary oocyte, and it stops in the metaphase of the second meiotic division. So what is released is oocyte, zona pellucida, and corona radiata. Yeah, all these. And this happens into peritoneal cavity. So now we have the secondary oocyte in peritoneal cavity, and it needs to touch the fimbria of ovarian tube, and has to like crawl on the ovarian tube inside its opening. If it doesn't happen, then it's then it dies, and it disappears by macrophages. If the sperm comes here and meets the ovum and the fertilization happens here, then an extrauterine gravidity can happen, and it can cause heavy bleeding, pain, and even when it's really nested here and starts to develop, it can even cause a death of the mother. So it's very important not to neglect such a symptoms of pain in the hypogastrium in the case of the menstrual cycle not coming period. So then the lady has to think about the extrauterine gravidity, and it has to be solved surgically. So what then happens after the ovulation and releasing of the secondary oocyte with ovary and the follicle? The follicle is still there, and it starts to change into a hormone-producing organ. So first, the antrum is filled with blood because it's 2 to 3 centimeters big. So it's called the corpus rubrum or hemorrhagic body. Then it's a bit contracted and successively the blood is absorbed and it changes into a yellow body, corpus luteum. It has got 2 layers, as I will show you, the granulosa and thecal cells. But in case there is no fertilization, then this corpus luteum works only less than 2 weeks. And then it starts to fade out, which is called luteolysis. And it totally fades out and there is no scar after that. But in case there's a fertilization and zygota, morula, blastula, blastocysta, and a nesting in the uterine epithelium, it starts then to produce an outer layer, which is called cytotrophoblast. So the cytotrophoblast of the embryo produces human choriogonadotropin hormone, which can be detected in blood and urine, and that's what's used in testing of pregnancy in urine. But the main function of this is to maintain the corpus luteum to persist, change into an endocrine active organ. So then it's called gravidity corpus luteum, and it produces hormones till the end of the 4th month. At this time, the placenta is already developed and can overtake the hormone production function. And then the corpus luteum is reduced and changes into a white scar, corpus albicans, which is really a fibrous scar. It causes a retraction of the surface, so the surface of the ovary is not smooth anymore, and it remains as a scar for a long time there. So what is the structure of the corpus luteum itself? So we start with the antrum filled with blood. Then the blood it clots and forms a scar from a fibrous tissue. The vessels start to grow inside, mainly in the granulosa, because they were in the outer theca, but not in the inner granulosa. And now the cells start to produce the hormones. That's why they developed the granules with lipids. So the internal layer called granulosa, then the cells are called granulosa lutein cells, as they are more yellow, containing more lipids, and they produce estrogens, which are one of the hormones produced here. So they produce estrogens from androgens. They use aromatase. So that's quite interesting that the estrogens are not produced directly, but they are produced from androgens. And all this is under the influence of luteinotropin hormone. And they also produce progesterone, which is very important to maintain the uterine epithelium, the uterine mucosa, the endometrium, to accept the blastocyst for nesting. So this is also produced in theca cells, so progesterone is produced there as well, and it produces the androgens, which then travel into granulosa cells to be changed by aromatase into estrogens. So the theca lutein cells, they are also producing the former stromal cells around follicle. And all this is covered by a capsule, and this capsule is produced by the external theca. So we then call these theca cells, thecal fibroblast. So 3 types of cells. Outside still the stromal cells, the fibroblast, which we just called the thecal fibroblasts. But inside the granulosa lutein cells producing progesterone and estrogens from androgens, and thecal lutein cells producing also progesterones and producing directly androgens to supply the granulosa lutein cells. So that's corpus luteum, and we can see how the scars looks like. Yeah, that's the corpus luteum. And when we come closer, we can see here nicely the granulosa cells. The arrows shows you the vessels, and then the thecal cells. So they are all active. Here we can see the former cavity, the antrum, which is filled with the blood. So this is corpus luteum, again nicely visible. The thecal lutein cells, the granulosa lutein cells, and here the blood clot. The external theca, the fibroblast here, and you can see here the surface with the superficial epithelium. And again, nicely formed corpus luteum with the thecal layer and the granulosal layer. So these are the most important hormone producing cells of corpus luteum. So to conclude, we distinguish an ovarian cycle. During the ovarian cycle, the follicle matures into the tertiary and Graafian follicle. Then the Graafian follicle ruptures, which is called ovulation under the influence of luteotropin. And then the corpus luteum develops, so it's called luteal phase. And you can see that it takes 28 days, so it mirrors the menstrual cycle. But it has got only 3 stages or 3 phases, and ovulation is very short phase. So there's the ovarian cycle, which is regulated by 2 hormones, and these 2 hormones are called follicle stimulating hormone, which is important for the first follicular stage, and luteinizing hormone, which is very important for ovulation and the luteal phase. Both are produced in the anterior lobe of pituitary gland, so in hypophysis, and they are regulated by direct feedback by the level of estrogens and progesterone, and also they are regulated from hypothalamus, from arcuate nucleus, by gonadotropin releasing hormone. So how the follicle matures? So the development is terminated in the 3rd to 6th month of the embryonal development. And then it starts after puberty. It starts from the primordial to tertiary follicle, which takes 3 to 6 months as well. It's called follicle maturation, and we have a theory of dominant follicle, which means that we have some up to 20 tertiary follicles, which starts to enter the follicular phase under influence of follicular stimulating hormone. And usually that with high sensitivity to this hormone is selected and continues to the mature one, and the other ones degenerate. Atresia or degeneration is very common process here, as I said, between the 1st to 6th months of the intrauterine development, we have some 7 million of follicles. And then it starts to be reduced up to 1 million at birth and 500,000 in puberty. And then, of course, some of them has to maturate, but usually it is reduced by 1,000 every month. So at the age of 45 to 50, there is only 1,000 of the follicles left. So that's unlike sperms, which are still produced and multiply. The follicles, so the oocytes, are in a definite number already at the 5th month of the uterine life, and then the best are still selected. So this was all for the ovary, the gonad, and now let's talk about the uterine tube, which serves as a place for fertilization and the first development of the embryo, so from zygota to morula, blastula, blastocysta, and it's then transported by contraction of the muscle layer and microvilli into uterine cavity, which takes several days, and then the function is over. It's a muscle tube, and it contains several parts. It's a hollow tube, so it has got 2 openings. One opening is inside the uterine cavity, so it's called uterine opening. And then we have this, which is called abdominal one, and it's opened inside peritoneal cavity, as I said. So when the mature Graafian follicle ruptures, then the secondary oocyte with the zona pellucida and corona radiata is released into peritoneal cavity and is attached to this protrusion, which is called the fimbria. And the longest fimbria is called ovarian fimbria, and it touches by action of the hormones. It is attracted to the place of the rupturing Graafian follicle, and then the oocyte can travel along the fimbria inside the ovarian uterine tube. So in case the fertilization happens outside uterine tube and extrauterine gravidity can happen. So the first part of the tube is enlarged, so it's called infundibule, and it's formed by fimbria. Then the largest 2/3 up to here are called ampulla. Then this narrower 1/3 is called isthmus. And then it enters the wall, and a very small part inside the wall, similar to urethra in a urinary bladder, is called intramural or uterine part. So 6 parts, 2 openings, and then infundibule, ampulla, isthmus, and uterine part. As for the wall structure, it's a typical tube, so it has got 3 layers: mucosa, a muscle layer, and serosa. So it's intraperitoneal organ, totally covered by peritoneum, except for the mesosalpinx, which is part of the broad ligament of uterus and brings vessels and nerves. The muscle layer contains inner circular and outer longitudinal layer of the muscles, and the wall, the thickness of the muscle wall increases towards uterus. And the mucosa contains simple columnar epithelium with cilia, and the cilia, their movements are mainly towards the uterus to move the oocyte, but also some strips of kinocilia, they move the sperms from the uterus towards ovary. So there are like two currents of them, but majority, of course, is for oocyte and then for the zygota. So the epithelium is higher during ovulation, and we have two types of cells: the ciliated cells, which moves the oocyte, zygota, and sperms, and secretory cells, which produces fluid for these structures to be moved, and also the fluid serves as a nutrition for the ovum and for zygota. Except for these cells, of course, we have the basal cells, and then we have PEC cells, but it's not so important to know about the function of the PEC cells, but they are 4 types of cells. As you can see on the section, it's a typical tube, so it has got folds inside, but the folds are very abundant here, and we have even several generations of them. So we have primary, secondary, and even tertiary folds. The folds, they decrease towards uterus, so they are most complicated in fundibule and ampulla. So here you can see that the folds are reduced towards uterus, as well as the number of the ciliated cells. Because what then happens is that the movement of zygota, which is bigger, is assured by muscle layer. So the muscle layer is reduced in opposite direction. So of course it is getting thicker towards uterus, and the larger is zygota, the more fluid is necessary. So also the number of the cells which secrete is enlarged towards uterus. Yeah. So less folds, less ciliated cells, but more secretory cells and thicker muscle layer. And you can nicely see here beautiful primary and secondary and tertiary folds. So this has to be the proximal part, so the ampulla. And when we come closer, we can see the simple columnar epithelium. Oh, sorry. Simple columnar epithelium with cilia here, nicely visible. We can see some basal cells here. And these spaces in between are large lymphatic lacunae in lamina propria. Here we come to isthmus, so you can see not so many folds here, and quite thick muscle layer then. So the isthmus, and that's all for uterine tube. The uterine tube is sometimes also called, as I come here, fallopian tube, as Gabriele Fallopi was the first who described that. So in English, you can find the term fallopian tube as well, but please use the systemic term uterine tube. And as salpinx as well, but do not mix salpinx with tuba auditiva, which is also called salpinx. But when you talk about salpingitis, salpingitis has inflammation of uterine tube, of course. But the salpingopharyngeal muscle is a muscle of pharynx. And when you come to uterus, uterus means pipes. It means a windbag of the pipes. So, and of course, it's a thick muscle wall organ, hollow organ. And the Greek terms for it is metra and hystera, which are used in metrorrhagy, which means bleeding from uterus, and hysterectomy, which means a removal of uterus. And hysteria is an old term for panic attack, and the idea was that the uterus is wandering throughout the body to brain and causes this specific states of women, but we know that's not true. That's why we call it now a panic attack, not hysteria. So let's come back to uterus. So it can be similar to stomach or urinary bladder. So the organs which should keep the content for a longer time. So of course here we need a thick muscle wall. So the function is for the development and nesting of embryo and development of fetus and then delivery. So then it has got several parts. We have a fundus, I changed the color. We have a fundus here on the top. We have a body or corpus here. We then have a cervix here. The cervix is this part. And the cervix has got this vaginal part. And then the supravaginal part. And then we have isthmus, which is this part. Isthmus is quite interesting as it looks as a body. So the main function is to extend and keep the embryo and fetus, and then to contract during delivery, but not isthmus. Isthmus works as cervix, which is during pregnancy to keep here this canal closed, and during delivery to relax and to be stretched. So isthmus looks as a body but behaves as a cervix. That's why it's very, very interesting. Then we have two horns, cornua, and the horn serves for entrance of uterine tube, and it serves also for ovarian proper ligament attachment, and it serves for ligamentum teres uteri, which is the round ligament of uterus attachment here. Then it has got two margins, right and left, and two surfaces, the anterior surface, which leans against urinary bladder, and posterior surface, which leans against rectum. So these are the parts. Here on median or sagittal section, we can see fundus is here, then the body, corpus. We can see here the isthmus. We can see the supravaginal part of cervix. And we can see the vaginal part of cervix. And then, of course, vagina. What about peritoneum? Peritoneum covers here the anterior or vesical surface. And you can see it covers half of it. It covers the whole posterior or intestinal surface, and it is in contact with the loops of small intestine. And we can see that the rectouterine pouch of Douglas is in contact with posterior wall of vagina, and then rectum is located here. And you can also see that the uterus and vagina are flipped to each other. So they are bent. So what about the internal structure? It's important to distinguish the body and the cervix based on the function and also pathology, as the tumors of the body and tumors of the cervix are different. I'll tell you now. the body usually suffers from tumors which are benign. So either we can have leiomyoma, which is a tumor of smooth muscle cells of the myometrium, or sometimes it changes into a sarcoma, so leiomyosarcoma. If there comes any carcinoma, adenocarcinoma, it comes after menopause. Cervix, on the contrary, suffers from carcinoma quite often, and it comes in young ladies, especially in those who smoke and who are sexually very active and not vaccinated against the human papillomavirus. So smoking and human papillomavirus are very risky, and that's why the cancer comes in young ladies. Now back to histological structure. The body contains a big cavity with uterine glands. The cervix contains a narrow canal with cervical glands. Of course, the difference is what they produce. The uterine glands produce fluid to support the embryo and fetus then, and the cervical glands, they produce mucus to close the canal, to not to allow the infection to come in. And it contains also folds, and the folds are arranged as leaves of palm. When the cervical glands are obturated, so they look as extended white spots. They are called Naboth ovula, because Mr. Naboth thought that they are eggs, but we now know that they are just obturated and enlarged cervical glands. Then we have two orifices, openings. We call them histological one. Internal is between body and cervix, so it's in between. And the external is the real orifice of uterus, and it's between cervix and vagina. Its shapes should be circular, but usually during delivery, during labor, it is changed into a cleft one, having an anterior and posterior labium. So during examination, gynecological examination using the mirrors, you can nicely see, according to the shape of the cervix, if the lady is a nullipara, so not giving a birth, or a multipara, so after one or more deliveries. So lower uterine segment is the isthmus, yeah, which looks as a body but behaves as a cervix during delivery. How the uterus is fixed? Of course, it's covered in the uterine, in a peritoneal duplicature called broad ligament, which is in frontal plane. This we already know. By horns, it is fixed by means of round ligament of uterus, ligamentum teres, which goes through the inguinal canal into greater labia, greater pudendal labia outside the body. So it also helps to fix it. But the main structure for fixations are the ligaments attached to the cervix. And it is transverse ligament of cervix, or in clinics called cardinal ligament of McEnroth, which is also in frontal plane. And we can see it here. So this is the cardinal ligament of McEnroth to the sides of pelvis. And then we have ligaments in a ventrodorsal direction. They come from pubic bone to urinary bladder, from urinary bladder to uterus, and from uterus to rectum as far as sacral bone. So this is an old terminology. It nicely describes how they travel. Purely anatomically, the most important are pubocervical. So this corresponds to vesicouterine pubovesical and the rectouterine one. So looking here, we can nicely see the pubocervical here and the rectouterine here. But you can see that the ligaments go really between all the structures, as I said before. Yeah, so we have this change, pubosacral change, pubosacral change from pubic bone to sacral bone. And we have this transverse cervical or Makenroth cardinalis ligament to the sides. So that's so-called suspensory apparatus, connective tissue. But the most important is a supporting apparatus, muscles, perineal muscles, but mainly levator ani and its muscle, a pubovaginal part of pubococcygeal muscle, which helps to maintain the cervix of uterus. And here you can see the normal position of uterus in median plane. And you can see that it's bent or flexed or flipped in the two spots. One is here between the body and the cervix. And then it causes so-called anteflexion. So the body is flexed against the cervix. And then in here, we have the whole uterus. Maybe I change the color. The uterus is here, flipped against vagina. So it's anteversion. So usually the position of uterus is anteversion and anteflexion, which is AVF position used in clinics. Okay? The position can be also different, as you can see in this figure. It can be also here up, which is called retroversion and retroflexion. And there's a danger of a rupture during pregnancy, as here we have sacral bone and promontory. And the retroverted and retroflexed uterus can be ruptured here by promontory. The normal position contains not only anteflexion, anteversion, but also it is usually moved a little bit to one side, so it's called lateral position. And it's usually a bit torted due to the course of rectum. So it's usually a dextrotorsion. So these four, anteflexion, anteversion, which are the most prominent, and lateral position, dextrotorsion, all these four forms the most common position of uterus. What about the blood supply? The blood supply is very easy, comes from internal iliac artery via the uterine artery, which comes from to uterus, and it's wavy here, like a splenic artery or facial artery are wavy, and gives a vaginal branch towards cervix and ovarian branch towards ovary and tubal branch towards uterine tube and round ligament branch, that means arteria ligament, the teres uteri round ligament branch into inguinal canal. What is important? It is ventrally to ureter. So during hysterectomy, it is necessary not to damage ureter here. And the gynecologists, they say that the water flows under the bridge which carries the blood. So uterine artery is located more superficially, so ventrally above ureter. When we come inside uterus, the arteries are all the time wavy again, as uterus has to enlarge 10 times during pregnancy. So we have the branches of uterine artery are called arcuate. They enter myometrium. Then they split into so-called radiate ones. They comes into lamina propria to endometrium, and they give direct branches to stratum basale, which is still kept there. And from these, again, wavy ones, which are called spiral arteries, they grow into stratum functionale, the functional layer, which is removed every month during menstruation. So this is the arrangement of the vessels inside uterine wall. As for the venous drainage, it's very easy, as we have here utero-vaginal venous plexus, which drains directly into internal iliac vein. It's nothing special about this. And for lymphatic drainage, it's very important. You can see that we distinguish two ways. One is anatomically and the other is clinically. So anatomically, the body and fundus are derived into lumbar lymph nodes, as ovary does, because these lymph vessels descend together with the ovary, so lumbar ones. The majority of the body is drained by iliac lymph nodes, internal, external, common. The posterior aspect of the cervix and part of the isthmus are drained into sacral lymph nodes. And from margins along the round ligament through the inguinal canal, it's drained into superficial inguinal lymph nodes. So 4 ways: lumbar, iliac, sacral, and superficial inguinal. That's anatomically. And clinically, we can divide this into the part which is drained from the body, and from the body it drains into iliac, lumbar, and superficial inguinal. That's from the body. So tumors of old ladies and tumors of young ladies are drained into sacral bone and internal iliac, coming from cervix mainly. So this has to be distinguished clinically from the body to lumbar, iliac, and superficial inguinal lymph nodes, from the cervix to iliac lymph nodes, and to sacral dorsally, which is similar to prostate lymph drainage. Let's come to the internal structure, so to the histology. Here, the 3 layers has got a special terms. Mucosa is called endometrium. You can hear the Greek term metra. So endometrium is mucosa, and mucosa is, like in uterine tube, a simple columnar epithelium, ciliated. So it contains the ciliated cells, and of course the cells which produces fluid, so secreting cells. But the endometrium contains 3 layers. A basal one, which is stable, very, very low one. And stable means no changes during the menstruation cycle, and it is not reduced, it is not slowed off during menstruation. So it serves as a regeneration area for mucosa. Then stratum functionale, so functional layer, sometimes called spongy layer, as it looks very there are many holes inside, like the Emmental cheese, and its height varies depending on the phase of the menstruation cycle. So it undergoes the changes and it is periodically slowed off. And then the superficial layer, which is quite thin, it contains no these holes, so it's called compact one. And the basal layer contains the basis of the glands from which they are again renewed. The functional layer contains the bodies of the glands, and the superficial layer contains necks of the glands. So now we know that the uterine glands are simple tubular glands producing the fluid for nutrition of the embryo. Of course, mucosa is composed of epithelium, glands, and lamina propria, or stroma, which contains granular cells, but mainly stromal cells. And they are very important as they also undergo cyclic changes, and they serve as a storage cells for the nesting embryo and for future placenta. So here we can see nicely 3 layers. So the basal layer, which still keeps there, it's constant, does not undergo the cyclic changes. Functional layer and compact or superficial layer. So you can see the compact layer here and the functional layer here, then, which really looks as a emmental cheese. And you can see the tubular, simple tubular coiled glands. So it just coils down like this. And even in the gland, you can see the simple columnar epithelium, of course, not ciliated. And if you look here, this is during the proliferative phase. And then during the secretion phase, you can see how enlarged are both the glands and also the stroma containing the stromal cells. The height of epithelium is also bigger. You can see how the stroma is enlarged, and the stromal cells, they are fed up with lipids and proteins, so they are changing into so-called pre-decidual cells, which means these cells are ready for a decidual reaction. Decidual reaction is a change of uterine endometrium into a future part of placenta, and these cells will be then eaten by cytotrophoblast. So the embryo and its covers will eat it during nesting, and it will serve as their nutrition at the first phase before the blood vessels develop here. So that was for endometrium. And now we come to the second layer, muscle layer, which is called myometrium. And the myometrium is composed of muscle cells, smooth muscle cells, which are spindle-shaped, not very long now, but still they are considered the longest cells in the human body. But their number and their size and length increases during pregnancy, so it undergoes both hyperplasia and hypertrophy. They are arranged in several layers. We have 3 layers here and 1 layer in serosa. For clinical practice, it is not necessary to distinguish these layers. So if you will just remember that the myometrium has got 4 muscle layers, it's fine, that's enough. It's very important, it has got quite high number of oxytocin receptors, which multiplies before delivery, as oxytocin is a hormone of hypothalamus released in posterior lobe of pituitary gland, which then causes contractions of uterus during delivery. So that's the muscle layer, and above the muscle layer is peritoneum, so serosa, which is called perimetrium. But not the whole uterus is intraperitoneal, so the extraperitoneal part is of course covered by adventitia, which is called parametrium. But the parametrium contains not only loose connective tissue, but also ligaments, so the dense connective tissue. And you may remember these ligaments as the supporting apparatus. So the cardinal ligament of McEnroe and the pubocervical and rectouterine ligaments and so on. So don't forget about these two kinds of the covers: peritoneum, which is perimetrium, like around, and parametrium, which is tunica adventitia, loose connective tissue, and dense connective tissue ligaments. So let's come to some slides. And you can nicely see mucosa. I just changed the color. So the mucosa is here. And you can see the glands. And of course, don't forget about lamina propria, which is all the way coming through the thickness of endometrium. And then the myometrium, which is here, containing here the vessels. So these are the radial vessels, which comes towards endometrium, and then the spiral arteries, they just go this way up in stroma of the endometrium. When we come closer, what is visible is the simple columnar epithelium of the glands and the cells of the stromal cells of lamina propria, which will then undergo the decidual reaction. So the endometrium has to undergo the changes, which are called menstrual cycle, which corresponds to the ovarian cycle. It has got 4 phases. And what is considered the beginning is the menstrual phase, which the lady then can feel as a vaginal bleeding. Before that, a pain can come, and the pain can be a part of the ischemic phase, which is just a 1 day. And after let's say 4 to 8 days of bleeding, a proliferative phase starts, and it terminates the day of the ovulation, when the endometrium is awaiting the coming blastocyst for nesting. So it's called the secretory phase. And if there is no nesting and not a development of cytotrophoblast producing the human gonadotropic hormone, which then maintains the corpus luteum to produce progesterones, there is no continuation of this. So what comes is the ischemic phase again. So that's the menstruation cycle, which will be then, of course, topic of physiology and gynecology. But to understand it, we should go shortly through that. What is important is the beginning of the menstruation cycle, which comes in puberty with the change of the LH and FSH hormones from pituitary gland. And of course, it terminates around 50s. It's called menopause. So FSH, the follicular stimulating hormone, and luteinizing hormone, LH, coming from the anterior lobe of pituitary gland. We can see that they have the important functions. The follicular stimulating hormone is important at the beginning for the ovarian cycle, for production of the maturation of the follicles. Then we can see what happens that under the descending level of follicular stimulating hormone, the estrogens goes up, and then as you can see, the level of estrogens falls down and starts to affect the luteinizing hormone level. And when there is a rapid change in the level of LH, the ovulation starts. And when the ovulation starts, then we can see here a raise of the progesterone, which is produced by the corpus luteum. Of course, also estrogens are produced in corpus luteum. And in case no nesting and no production of human choreogonadotropin happens, and the pregnancy can start, then you can see that the levels of the corpus luteum hormones go down as the corpus luteum fades out here. And if you see what happens with the menstrual, with endometrium, we can see that under the influence of estrogens, there's a slow proliferative phase. And then in ovulation, there's a secretory phase that the whole endometrium and mainly lamina propria and stromal cells are filled with lipids and proteins. And in case there is no pregnancy, you can see this rapid decrease of hormones, which means closure of spiral arteries, ischemic phase, and then the menstruation. So the majority of the endometrium is just slow away. So now let's go through the phases again. So we start with the menstrual phases, which is provoked by a rapid decrease in the level of progesterone, and it causes the spasm of spiral arteries. So the whole endometrium, except for basal layer, is slowed off, which is some dozens of milliliters of blood. And the re-epithelialization started after the 5th day of the menstrual phase. And the mucosa is quite thin at that time, less than 1 millimeter. So the proliferation under estrogens produced in the maturing follicle in granulosa cells happens, and it happens by hyperplasia. So the stratum functionale, the functional layer, start to appear. The glands are getting longer, and at the end of this phase, they start to coil. The mucosa is 3 to 5 times thicker. And when there's an increased level of luteinizing hormone, the ovulation starts just in the middle of the whole circle, so on the 14th day, which can be also accompanied by very small bleeding sometimes, and even by some pain during ovulation in some sensitive ladies. So in proliferative phase, we can see this is some 3 millimeters, and we can see growing glands and growing thickness of the functional or spongy layer. So after ovulation, the secretory phase starts. So it's now not under influence of estrogens, but under influence of progesterone, coming mainly from the granulosa lutein and theca lutein cells. So now not hyperplasia, but hypertrophy happens under the influence of progesterone in the functional zone. So the glands are very coiling, and the compact part stays straight because they are the necks of the glands. And the secretion starts, and it contains mainly lipids, glycogen, and a bit of mucin. So this is what the cells contain. And don't forget about the pre-decidual reaction, which means that the stromal cells of lamina propria are filled with lipids and glycogens. If the pregnancy starts, then these cells are multiplied, but they are finally eaten by the extending cytotrophoblast of the embryo. So they serve as a nutrition. And you can see the secretory phase. This is already twice larger, 7 to 8 millimeters. And you can see a really enlarged and hypertrophied coiled glands. Yeah, and the compact part and the basal part still remains the same. And then comes the ischemic phase, and it's to the rapid decrease of the progesterone level based on fading out of the corpus luteum. So what happens is the constriction of spiral arterioles, ischemia, and necrosis. And the leukocytes comes and the degenerative process starts. So there's up to 100 milliliters of the menstruation blood. And there are some enzymes in mucosa which stops clotting. That's why the blood can get away and can take away the redundant compact and spongy layer of the epithelium. And then a contraction of myometrium and vessels happened, and it stops the bleeding, and the menstruation cycle can start again. So you can see the ischemic phase. Mainly you can see here how the superficial layers are blooded and ischemic, getting darker. So that's all for the menstruation cycle. Just a little note on the isthmus. The isthmus, as I said, is part of the body which behaves as a cervix during delivery. So concerning its structure, it contains less vessels, which is very good to start here the cut in caesarean section. So it's approached here via isthmus. It has got lower endometrium and does not undergo the cyclic changes because it behaves as a cervix. And we have talked about this part, which is the isthmus. So we also have so-called internal orifice, internal histological orifice of the uterus, because it's the most caudal part of the cavity. And now let's talk about the cervix. The uterine cervix consists of two parts. One part is not visible from outside, and it's the supravaginal part. So it's the superior part which is surrounded by parametrium. And then we have the vaginal part, which is visible in vagina. So it protrudes into vagina. It is well visible during the vaginal examination using the mirrors, and it is covered already by the vaginal epithelium, which is stratified squamous non-keratinizing epithelium. That's why we call this part of the cervix ectocervix, as it is displayed outside from the uterine cavity. Inside the cervix, we have a cavity which is called canal, which is because it's very, very narrow. And it is not smooth, but it contains the palmate folds, as I said. In the mucosa, there are glands, which we call cervical glands, and they open into so-called crypts. They produce an alkaline secretion, and the density depends on the phase of the cycle. So the only cyclic changes here are the changes of density of this mucous plaque, or in Latin obturamentum. And during the secretion phase, so after ovulation, it is less dense, so it is thinner, and the sperms can get easily through. In the other parts, it's thicker, so it protects the uterine cavity against bacteria and other infections to come in. So endocervix is then the epithelium inside the canal, and it's the typical simple columnar epithelium with some ciliated cells, but not much, and mainly secreting cells, but they secrete mucus here. So that's the endocervix. The ectocervix is already the vaginal epithelium. So when we come to a figure, we can nicely see here some parts. This is the isthmus. So then this is the internal histological orifice, cervical canal, lined with simple columnar epithelium with ciliated mucous cells. So this part is the endocervix, and it corresponds to the supravaginal part of the cervix. Now the vaginal part is this part, so this is the vaginal part of cervix, covered by simple squamous non-keratinizing epithelium, so this is the ectocervix. Here, this opening is the external histological orifice, and we can see a sharp transition of the epithelia, which is called squamocolumnar junction in clinics, because that's a squamous vaginal epithelium and columnar endocervical uterine epithelium. And this is again a spot where the cancer can appear. So a cancer of cervix usually appears and starts at this junction, which is a place of the minor resistance. So when we come to the exocervical mucosa, we said it's a vaginal surface, non-keratinizing stratified squamous epithelium. And at the borderline, the columnar epithelium, not visible in nullipara. But after birth, when the osteum changes, after deliveries, when the osteum changes from round to this oval, then it usually starts to be seen, yeah? And then we call this ectropium. So ectropium means that the endocervical simple columnar epithelium is already visible on the cervix during the vaginal examination, okay? And it happens after deliveries. We have to distinguish this from ectopia. Ectopia is pathological. It means that the epithelium starts to change. So it undergoes a metaplastic process. So it's already a metaplasia, which is a step before tumor. You will talk about this then later in pathology, don't worry. So the columnar epithelium is replaced by stratified squamous epithelium. So the sharp borderline then changes, and we call this transformation zone. And what to do with that? It's just necessary to cut it. So in case you look at the cervix like this, and you can see here some spots of changed epithelium, you need to cut it away, and you cut it in a cone-shaped way. Yeah, this is the surface. So it has the shape of a cone, so it's called conization. And this is how you prevent the spread of the cancer. And it is usually caused, as I said, by HPV. So it is necessary to vaccinate both young ladies and young boys, because the young boys are then the guys who transfer it and who can be the infectors. So we can look at the sharp junction, which is well visible here. So that's the difference. That's the borderline between the simple columnar epithelium and then here the stratified epithelium. You can see the glands. the cervical glands producing mucus. So that's the squamocolumnar junction of the uterine cervix. And again, here we can see the junction here between the simple columnar endocervix and stratified squamous non-keratinizing exocervix. Yeah, you can see the sharp squamocolumnar junction here. And what you can see during the examination, vaginal examination, or colposcopic view, because kolpos means vagina in Greek, so colposcopic view is the view in mirrors. So this is a multipara, and you can see here the squamocolumnar junction, so a transformation zone. In case you see such a wide dot, it's the cyst of Naboth, which is a obturated cervical gland, so that's a normal. But what you can see then is the different epithelium, and the different epithelium can be already the metaplasia, so the precancerosis, which has to be solved. And you can see it here, the metaplasia. So a normal columnar epithelium and the stratified epithelium of vagina here, and then here a cluster of the cells, which are all the same. Yeah, you can see here the basal cells, and the basal cells look very similar to all these. So this is the metaplasia in a squamocolumnar junction has to be solved. So the squamocolumnar junction, I just change the color. Nicely visible here. Yeah. So what is really red is the endocervix, the simple columnar epithelium, and the rest, what is pinker, is the vaginal squamostratified. And here you can see a different stages of the cervical metaplasia, which abbreviation is SIN. So this is already a pathological state, so precancerous metaplasia. And you can see here differences. This is what you know from your microscopes. So the basal layer, which is darker, and the superficial squamous layer non-keratinizing. And you can see here in the in the gravest stage, you can see that all the layers look the same. So this is a tumor. And again, a figure showing this pathology. So what is then the message? The message is that the ladies should visit their gynecologist twice a year, and all the time examination, colposcopic examination with mirrors should be performed. To conclude uterus, we just have to talk about some developmental remnants which can be found along uterus, but also uterine tube and close to ovary. We know that in a female, the mesonephric duct of Wolff produces the excretory urinary system. That means part of the urinary bladder, and then ureter, renal pelvis, and calyces and collecting ducts. But then the part which is destined for the female, for the male genital, internal genital organs, that fades out. But when it does not fade out, it can resist here as a so-called longitudinal duct of Gardner, which you can see here along the margin of uterus. And another remnant are mesonephric ductuli. Yeah, as we know that the mesonephros is the second stage of development of the kidney, which is not necessary. So it should fade out as well, but it can produce a small transverse ductuli, which we can see here. And these two structures can be connected, and that's why they are called epophoron. So please, here you can hear ophoron, which is ovary in Greek, and epiophoron, like above ovary, and you can see that it can be above ovary as far as the margin of uterus. So that's the Rosen-Miller's epophoron, and it's located in mesosalpinx. Then we can have a parophoron, so next to it. It's also a remnant of mesonephric tubules, but it's located closer to the uterus, so it's called the Cobble's parophoron. And then the most common and usually most clinically important is so-called vesiculous appendices, which means it forms such a pouch, and it is called also Hydatidis of Morgagni. Morgagni was a founder of pathology, and he also described this case. And you can see this enlarged cyst, and it's a remnant of the Wolffian duct as well. So to conclude uterus, some clinical points. We have talked about the tumors. The benign tumors of the body are leiomyomes, which comes from smooth muscle cells. They can change into leiomyosarcoma, into malign one, but the most common malign is then adenocarcinoma of the cervix. Endometriosis is a very unpleasant state when the endometrial epithelium, so endometrium itself, can be found somewhere else than inside the cavity of uterus, like on peritoneum or in the wall of rectum. And of course, it also undergoes the menstruational cycle, so the cyclic changes. So it can cause bleedings, pain, and it can be also a cause of sterility. Amenorrhea means no menstruation. Dysmenorrhea means problems with menstruation, which can be problems in timing, so the cycle is irregular, but mainly problems with pain and other symptoms. Okay, menorrhagia, bleeding, and menometrorrhagia and bleeding during menstruation cycle are just the terms you should understand. Another organ of the internal female genital organs is vagina, and in Greek kolpos. So kolpitis is the inflammation. You have to distinguish this from vaginitis. Vaginitis is inflammation of synovial vaginas of the hand or foot. And colposcopy is the examination of the uterine cervix using mirrors. It's a muscle tube, some 10 centimeters long, and it has got anterior and posterior wall. And the entrance we can find in the vaginal vestibule, which is called ostium, and it terminates with fornices. And the fornices, we have 4 of them. So if we have here a uterus, and the fornices can be found here, and this is the vagina with the ostium. So we have the anterior fornix, which is quite shallow, posterior fornix, which is very deep, and the lateral fornices are on the wall, on the sides. So when we look from here, we can nicely see the cervix, let's say a cervix of nullipara, and we can see the anterior fornix and the posterior fornix, and then the lateral fornices, which means that there is a groove around. Yeah, so 360 degrees groove. But it is called, it has got 4 fornices, and the anterior and posterior fornix we can install the mirror during the colposcopic examination. And we know that peritoneum covers uterus from both sides and then goes this way. So the rectouterine pouch of Douglas is in contact with the posterior fornix. So the posterior fornix is the most important. And the ostium in female kids, there's a hymen, which is a remnant of the development. It is usually pierced, which is called a defloration, and it is necessary to be pierced before the first menstruation. Otherwise, the menstruational blood remains in vagina and can be infected. The remnants then on the walls of ostium are very small papillas, which are called caruncles, hymenal caruncles. The inside is called canal, vaginal canal. It contains on the wall folds, but the folds are called not plice, but rugae. Yeah, I don't know why, but they are called rugae. And on the anterior and posterior wall, they are elevated into 2 columns, anterior and posterior. These rugae and columns then usually disappears after first delivery. And in the anterior wall, we have 2 interesting structures. One is due to urinary bladder and the other due to urethra. In urinary bladder, we have so-called triangle. Yeah, and this is the Lietot's triangle in the urinary bladder. And it is adjacent to the anterior wall of vagina, producing a smooth, fold-free area, which is called a trigonal area of Pavlik. Karel Pavlik was a Czech, very famous Czech gynecologist who worked in Vienna in 19th century. He was the first to describe this. And urethra here also protrudes in the anterior wall and forms here a protrusion which is called carina. And you may know that carina means a keel of a ship. So you can palpate this carina on the anterior wall of distal vagina. So what is behind and what is in front? We can see here, I just changed the color. You can see that behind is rectum. So behind we have a rectovaginal septum, and here in front we have a uretrovaginal septum. So these are 2 septi which just divide vagina from anterior urethra and posterior rectum. And we have already talked about Douglas rectouterine pouch, which is the most caudal pouch of peritoneal cavity in females. So any fluids or blood can be collected here. So you can palpate it via vagina. And in case it's inflamed or there's blood, it's painful. It can be punctured via vagina, and even we can put an instrument, an endoscope inside. So you know that colposcopy is if you look inside vagina, but if you look inside the Douglas space, we call it kildoscopy. Why it's called kildoscopy? As Douglas pouch is a blind sac, and it is also called in English from an old French word cul-de-sac. So cul-de-sac means a blind pouch. So kildoscopy is an endoscopy of peritoneal cavity via this pouch. Pubovaginal muscle, part of the pubococcygeal muscle, which is part of levator ani, which is part of pelvic floor, supports uterus. As we know, it's the active muscle supporting apparatus, and it forms a protrusion below cervix, which is called a promontory of Thomas. It's also palpable. The blood supply, because it's a muscular tube, it receives many vessels along its course. All comes from internal iliac artery. So from above, it's the vaginal branch of uterine artery. From below, it's vaginal artery of internal pudendal arteries. They are constant. Then we have smaller vaginal branches of middle rectal artery, but the middle rectal artery can be missing. The same serves for vaginal artery, which is a direct branch of internal iliac artery, but can sometimes miss. All these arteries has got short venous branches, which drains directly into uterovaginal venous plexus, and it drains into internal iliac vein. Also, it is drained by internal pudendal vein, traveling through the Alcox-Pudendal canal and curving around the ischial spine. The lymph is drained into internal external iliac lymph nodes because it's located in lesser pelvis. And what is superficially, so the vaginal vestibule is drained into superficial inguinal lymph nodes. What about the internal structure? So again, we have mucosa, muscle layer, and adventitia. So let's start with mucosa. We have the folds called rugae and anterior and posterior columns. The epithelium, as I said, stratified squamous non-keratinizing. Similar covers the cervix like ectocervical epithelium. The cells, they contain a high amount of glycogen, which we can nicely show by Pass positive reaction. Why glycogen? As we need an acidic pH in vagina, so it's normally colonized by lactobacillus species, mainly Lactobacillus acidophilus, which utilizes the glycogen and produces lactate during its anaerobic glycolysis to get energy to live. And the waste product lactate then causes a reduced pH, which then kills all other bacteria. So this is very important. And after any antibiotic treatment, it is necessary to reinstall the lactobacillus population by eating yogurts or any medicaments with lactobacilli. It's very interesting. There are no glands there. So the surface is lubricated from cervical glands and mainly by transudation from the layer below. They are lymph node nodules in mucosa, in lamina propria. They are scattered. They are not very abundant, just few of them, but they serve here as a mucosa-associated lymphoid tissue. Yeah, don't forget this. We know this mainly from GIT as, for example, the Peyer's patches. So here they are they are not aggregated. They are just solitary and few. The transudation comes from spongy layer below. So this is very unique for urethra and vagina, this spongy layer. And the function in urethra was to maintain continence. The function here is to maintain the erection. That means the erectile bodies of the clitoris and bulbus vestibuli are filled with blood, the same in vagina to be more elastic during copulation. So it contains elastic fibers and venous plexuses And these venous plexuses allows the transudation of the fluid during copulation. Then a muscle layer, circular internal, longitudinal outer one, and majority of vagina is covered by adventitia, except for the posterior vault, posterior fornix, which is in contact with Douglas pouch. How we call the adventitia? In uterus, we call it parametrium. Here, we call it paracolpium. And the epithelium undergoes, again, cyclic changes. So we should know it more in detail. And it has got 4 layers. Of course, the basal layer and the superficial layer. And in between, you can find another 2 layers, parabasal and intermediate. And what happens is proliferation, differentiation, and the glycogen storage. The epithelium contains also dendritic cells because they serve as the antigen-presenting cells for the lymphoid nodules. And the cyclic changes, they mirror the proliferative and secretory phase of the menstruation cycle and endometrium. So the cells containing acidic cytoplasm we can find during the proliferative phase and basophilic cytoplasm in secretory phase. This can be taken by exfoliative cytology, and it can be easily examined by microscope. Yeah, so we can verify the circle, the menstruation circle by this method. So if you look at the slide, you can nicely see the stratified squamous non-characterizing epithelium. Yeah, with the basal layer and the parabasal layer. Then you have the intermediate one and of course the superficial one. So 4 layers and lamina propria, and below the muscle layer here you can see the tunica spongiosa with the vessels, the venous plexuses. Oh, when we come closer, again the basal cells, the parabasal cells, they are melanocytes, very few of them. The intermediate cells will start to contain glycogen, and of course the very flattened superficial cells. And nicely visible where we start to collect glycogen. So these are the intermediate layer cells. So this is the superficial layer, intermediate, parabasal, and the basal is the thin one here. And the pus reaction shows you the accumulation of glycogen, as I said, and the spongy layer containing vessels and elastic fibers. And again, the detail to the accumulation of glycogen. So now we know that colposcopy is the examination of the vagina and uterine cervix with mirrors. Coulodoscopy is endoscopy of peritoneal cavity via posterior vaginal fornix and Douglas. Space exfoliative vaginal cytology is that you just take the surface cells, and under microscope you can distinguish the proliferative phase with acidic cytoplasm and secretory phase with basophilic cytoplasm. Of course, the bacterial content of the vagina is physiological, which is MOP number 1. This is used only in Czech Republic, but you can encounter this at the gynecology departments, so please remember these. And all the pathological conditions containing different bacteria like Neisseria, chlamydia, and so on, they are They are numbered 2 to 7. So this is just to know what the abbreviation MOP means. And then episiotomy is a cut of the perineum during pregnancy. During delivery. It is not done mandatory, but in case a rupture of perineum is here, the danger of the rupture can continue into rupture of external anal sphincter, which then result in incontinence. So that's why the episiotomy is sometimes performed. And a very famous G point does not anatomically exist as a specific point. It is just a place in distal vagina where we have more venous plexuses, and during sexual arousal, these plexuses are as erectile bodies filled with blood, and they compress the nerve endings. That's why it is a place of the easiest stimulation. But anatomically, the point does not exist. So we slowly moved from internal to external genital organs, and you can see now the figure of them. So what they contain. They are called either vulva or feminine pudendum. This term is considered in English language a non-polite, but in Latin it is used, and in non-English speaking countries this is not considered non-polite. So pudendal nerve, pudendum is normally used and not felt as an offensive term. So the first structure is this, which is called tubercle of Venus, or mons pubis, which is a part of the skin filled with fat pad and covered with hairs. And it is considered as an intrinsic part of the female body. That's why the term tubercle of Venus during the sexual arousal. The vulva is then bordered by greater labia, which are covered by a typical skin. Then minor labia, which contain no hairs and from no other glands than mucous glands, and they contain no fat. And they also border so-called vestibule. And the vestibule contains several openings. We can see the ostium of vagina, which was closed by hymen before, and we have here just the remnants, which are called the carunculae. Yeah. Then we have here the external ostium of urethra, ventrally. And here on sides, I just changed the color, we have the ostia of vestibular glands. We have two major vestibular glands, and then we can have some minor ones here. And don't forget that the glans clitoris is part of the vestibule, and we have here several folds. We have a posterior commissure here, and the anterior commissure here, and the prepuce of the clitoris, which is another skin fold. So this is these are the major parts of vulva. And now let's talk about the labia in detail. So the greater labia or major labia, they just contain connective tissue, adipose cells, and a bit of smooth muscle cells. And it's called tunica labiorum, which is corresponding to tunica dartos in a male. And the outside aspect is a normal skin with hair and all the glands. So mucous glands or sebaceous glands, sweat glands, and even aromatic glands. On the inner aspect, there are no hairs. That's the only difference. Then we come to lesser labia or minor labia. No adipose cell and only mucous glands. The epithelium is still stratified squamous, but keratinizing only slightly. And as I said, there are no sweat glands, and the sebaceous glands produce a special secretion, which is called smegma. And then the cleft between the lesser labia is called rima, so pudendal cleft. And from anterior and posterior, it is bordered by a commissure. And mainly the posterior commissure is ruptured during delivery. So if you look here, this is the posterior commissure, sometimes in clinics called fourchette, and that's rupturing during the delivery. Yeah, the anterior commissure, it still keeps here, and this is the clitoridal prepuce. So again, the openings of external urethral opening, the vaginal opening with remains of hymen, and the openings of a lesser vestibular glands and the greater gland here dorsally. So the vestibular glands are typical mucous glands. We differentiate the minor ones, which are not clinically important, and the major ones. They are called Bartolini glands, and their inflammation is very painful, and it's called Bartolinitis. So that's why we should know the eponym. And it is homologue to male Cowper's bulbourethral glands. So the function of both is to lubricate the areas of interest. So in the male, the spongy part of the urethra, and in female, the vaginal vestibule. So it lubricates this during sexual arousal. They are located both inside the urogenital muscle floor, so in perineal membrane, and they are tubo-alveolar mucous glands. And then we have here two cavernous bodies. One cavernous body is this one, which is a vestibular bulb. It's a paired organ, so right and left is connected here in front of vagina. And it is an erectile body. The other one is clitoris. And if you remember penis, on the section of penis, we had two cavernous bodies and one spongy body with urethra. In female, we have these two cavernous bodies forming here the same as in penis. So the two crura of penis, two crura of clitoris. But the spongy body is not here. The spongy body forms this bulb of vestibule. And during the sexual arousal, it's also filled with blood, and it maintains the shape of the vaginal ostium during copulation. So when we come closer, we can see the bulbus here. The commissure of bulbus here below the clitoris. This is the crus of clitoris, and we can see the glands of clitoris and the body of clitoris here. So the shape of clitoris is like that. Yeah, it has got two crura and a glans and a quite acute angle here. This is the suspensory ligament of clitoris, similar to suspensory ligament of penis. And here you can see nicely the P-shaped greater vestibular gland of Bartolini opening into vaginal vestibule. What is the blood supply? The blood supply comes from two sources. External pudendal arteries, the deep and superficial, comes from femoral artery, that means from external iliac artery. and they supply the anterior labial branches. From posterior, we have the internal iliac artery via the internal pudendal artery, which gives the posterior labial branches. But it, of course, supplies the clitoris, so the deep arteries into cavernous bodies, the dorsal clitoridal artery on the dorsal surface, and the bulbar artery to the vestibular bulb. Yeah, as in male, we have arteria bulbi penis into the spongy body. Here, the vestibular bulb artery as well. The veins drain the same way. So we have the superficial dorsal vein and anterior labial vein via superficial and deep pudendal external vein into great saphenous and common femoral and external iliac, of course. And dorsally, the deep clitoridal vein and posterior labial vein and the vein from vestibular bulb, they go via internal pudendal into internal iliac, and they both then join into common iliac. So lymph drainage is to superficial inguinal lymph nodes, but it can even cross the midline because the structures are very close. And the innervation comes again from anterior and posterior direction. So through inguinal canal comes the ilioinguinal nerve and genital branch of genitofemoral nerve. So they are two somatosensory nerves for these areas. And from dorsally come the pudendal nerve S2 to S4, and it gives branches to clitoris. So we have dorsal nerve of clitoris for the somatosensory innervation of the glans. We have the posterior labial nerves supplying the lesser and greater labia, and we have perineal nerve supplying the skin of perineum. Don't forget that the cavernous nerves, they do not come through this, but they come through inferior hypogastric plexus and cavernous nerves directly. It's similar to the cavernous nerves of the male. Don't forget that they can be harmed during prostatectomy in male. They are not usually harmed in female because there is no prostatectomy. So to conclude, we have to talk about the perineum. What is a perineum? Perineum is a space between anterior wall of anus and posterior wall of vagina. So when this is vagina and urethra, then the perineum is this one. Yeah, that's the perineum. Perineal region is, of course, the whole region here, but the real perineum is this one. The perineum anatomically is the perineal body. The old term is a tendinous center, but we now know that it contains not only collagen fibers, but also smooth muscle fibers, nerves, vessels, even loose connective tissue. So it's a complex organ, so we call it a perineal body. There are some other structures we have to distinguish, and that's the anacoccygeal body, which is similar structure but located here dorsally. We come to the other terms, but we know that on the sides here we have the ischioanal fossa. And on the side of the ischioanal fossa we have the pudendal canal of Alcock with the internal pudendal vessels and pudendal nerve. And I talked about episiotomy. So if there's a need to cut the perineum during the delivery to prevent the rupture, it is performed in this direction. Why it is not performed in other directions? Here is the external anal sphincter, and here are the cavernous bodies, so the vestibular bulbs. So it is necessary to cut it in the place of not harming a muscle, not causing a bleeding. So that's why in this oblique shape dorsally, either left or right side, doesn't matter. And urogenital floor, what is it? Urogenital floor is an old term for perineal muscles. I prefer the term floor as some of the muscles, 4 of them, really forms a floor. And above the floor, there is a ring of sphincters. So you can call it perineal muscles, you can call it urethral floor muscles. Yeah, both of them are correct. And the center of it is the perineal body. So if you look here, we can see the perineal body in female or the perineum and in male. And the muscles themselves, they are located here. So in the anterior thirds of the pelvic outlet. So which are these muscles in male? Then we come to female. So in male, we have 2 muscles which compress the erectile body. So we have ischio-cavernous muscle here. So you can see it comes from ischial tuberosity along ischiopubic ramus and it continues into cavernous body of the penis. So that's the ischio-cavernous muscle. The other muscle is bulbospongios. It starts from perineal body and continues into spongy body. Yeah, it's also paired. It's a bulbospongios muscle. And then we have 2 perineal muscles. So we have deep one from the perineal body towards the ischial tuberosity. So that's the deep perineal one. And it forms the majority of the floor. And then the superficial one, which is very thin and not important functionally. Just clinically, it's an orientation that is the posterior border of the urogenital floor. So there's the superficial transverse perineal muscle between the perineal body and the ischial tuberosity. In this, we can also see the ischioanal fossa. The ischioanal fossa is here. There's a communication to the others, to the contralateral ischioanal fossa below the anococcygeal body or ligament. So don't forget we have here the anococcygeal body or ligament. So there's a communication below, and it also communicates ventrally. So ventrally, it continues here as the anterior or pubic recess, which is blind. It has got a shape of a trilateral pyramid, and it's called pubic recess of ischioanal fossa, and it's located here in between the urogenital floor before and pelvic floor. This is pelvic floor muscles and pelvic floor above. Yeah, I will show you on the frontal sections as well. So now let's move to a lady. So ischio-cavernous, bulbospongios muscle are here. Superficial transverse perineal as well. So 3 of them are here. Which we miss? We miss this one. The deep transverse perineal. Why? This area we call a perineal membrane because it contains more connective tissue than muscle cells. Of course, there are muscle cells, but because there is more connective tissue, it is not considered a muscle, it is considered a perineal membrane. So that's the difference between male and female. 4 muscles in male, yeah, as you can see, 4 muscles in male. And this muscle is not present in female, as we have here in female more connective tissue, and we call it perineal membrane. Concerning the other muscles of the perineal group, in both we have the sphincter of urethra, male and female. So they are round. And in female, we have another two muscles, a horseshoe-shaped compressor, and in below, a oval-shaped ureterovaginal sphincter. Yeah? So you have a circular sphincter of urethra, you have a horseshoe-shaped compressor, and oval ureterovaginal sphincter. All of them, you can see that they are like one muscle with different slips, yeah, and they serve for voluntary contination, voluntary urine continention. So they are innervated by root S4, so it travels mainly by pudendal nerve and its branches perineal nerves of pudendal nerve. But they also receive fibers from anterior branches of sacral nerves, direct branches, and because they contract during ejaculation and it's a reflex, they are also supplied by visceromotor splanchnic sacral parasympathetic nerves. And now, just these two triangles, which you already know, they border the pelvic outlet. So the pelvic outlet is not one plane, but two planes formed by two triangles. And the urogenital triangle is the triangle filled with urogenital floor, all the perineal muscles. So that's, again, a view of the urogenital triangle. So we just have to repeat all the structures here. So we have a crus of clitoris covered by ischio-cavernous muscle. We have the body and the glans of clitoris, which protrudes into vaginal vestibule. We have a bulb of the vestibule, also vestibular bulb, which is covered by bulbospongious muscle. We have here the anterior and posterior commissure and external urethral orifice and the ostium of vagina. Don't forget the Bartholini's greater vestibular gland. And here, this is the perineal membrane, mostly connective tissue, partially a muscle fibers, and very, very reduced superficial transverse perineal muscle here. So, and there, don't forget, this is perineal body, the real perineum. You can see that it's supplied by branches of pudendal artery, internal pudendal artery and vein, and branches of pudendal nerve. And this is the male one, we just can skip it, and we come to the ischioanal fossa just to review it. Don't forget that it is bordered from above by pelvic floor muscles and its fascia, and medially then by external anal sphincter. Laterally, it comes as far as sciatic tuberosity, and the walls are formed by internal obturator muscles, so covered by obturator fascia. Dorsally, it comes to sacrotuberal ligament and the internal surface of gluteus maximus muscle. And caudally, it's opened and it's covered only by superficial fascia. That means the membranous layer of subcutaneous tissue called the superficial perineal fascia. What is the content? Fat pad called corpus adiposum of ischioanal fossa, and on the wall, pudendal canal containing internal pudendal vessels and pudendal nerve. And ventrally extends a pubic recess containing the same, reaching the pubic symphysis, but not continuing to the opposite side. So it's a cul-de-sac, a blind recess. So this is just to show you where it's located. Yeah, you can see that it's bordered from above by pelvic floor and dorsally by sacrotuberous ligament. We don't have here the gluteus maximus muscle to show, and from below just by the subcutaneous tissue stratum membranosum. So this is the male one. Yeah, again to present the fossa, and we are ventrally in the section, so we present only the recess. So the pubic recess is bordered by pelvic floor and its inferior fascia, obturator, internal obturator muscle and its fascia, and from below by, in male, transverse perineal deep muscle. And it contains fat pad. When we see here below the deep transverse muscle, we can see the ischio-cavernous muscle and crura of penis, pulpospongious muscle and the bulb of penis. And we can see here, this is the superficial perineal fascia. And in female, again, a section ventrally. So we can see again levator ani muscle with the inferior fascia, internal obturator with obturator fascia, pudendal canal, perineal membrane, yeah, more connective tissue than muscle, and below crus of clitoris with ischio-cavernous muscle, bulb of vestibule with pulpospongious muscle, superficial perineal fascia, so the stratum membranosum. This is the deep perineal fascia here. So that's all for today. Thank you very much for the attention and have a nice day. Bye-bye.